I've been an ER nurse now for 15 years, and it's what I love to do. I've always known from nursing school that I wanted to work in the ER. I like the fast pace, I like the excitement, I like the wide range of patients from small lacerations to major traumas. One of the most memorable traumas I've ever experienced was a gentleman who was involved in a plane crash. He was the pilot of a single engine plane, and his job was to swoop down and hook the banner that he was going to fly over crowds during big events like the marathon. And that was his job. Unfortunately, when he was coming down to pick up and hook the banner, something went wrong and the plane crashed and smacked the tarmac. So we're all at work one day and doing our usual thing, not crazy busy, and then the radio goes off. We hear the CMED radio go off, and it says, it's the EMTs, and they say to us, we're coming in. We have a 45-year-old male involved in a single-engine, small plane crash. He's moaning, not answering questions. We're going to intubate him so that we can secure his airway, and we'll be there in a few minutes. We suspect major internal injury, but there's nothing obvious injury, nothing broken or noticeable from just looking at him. So we jump into high mode. All the adrenaline's rushing. I'm the next person up to take the trauma. So I go in there and get ready at my station to record. So I'm the one taking the patient, I'm the one recording everything that's going on and keeping track of it all. All the other nurses fall into their positions. One is going to put in the major IV lines in both arms. One's going to hook the patient up to the monitor. One is going to work the code cart and get out all the drugs. And one is going to work our rapid infuser so they can put massive amounts of blood and massive amounts of saline and lactated ringers into the patient to maintain blood volume since we suspect he's bleeding internally. So we're all pumped up. We're going to do this. We're going to save this patient. Everything's going to be great. And then just as they should be arriving, the radio goes off again. And the EMTs say, we're pulling up to your hospital. The vital signs that we said were stable are now gone. He's just coded. And chaos breaks out. So now we are in super adrenaline mode. Patient rolls in on the stretcher. The EMTs are giving us the quick bullet points. We transfer him over onto our stretcher, and we begin resuscitation. And we're pumping fluids into him, and we're pushing drugs, and we're pumping blood products, and we're doing everything under the sun. But we know he's bleeding internally, and we're losing him, and we're not getting anything back. And eventually, we crack his chest open. They cut his chest open to see if there's some bleeders that need to be cross-clamped and brought to the operating room to be repaired, or if there's even any blood volume left in the heart so that we can restart it and get it going. And unfortunately, after what felt like hours working on this patient, we had to call it. We couldn't save him, and he died. Now, when a trauma comes in, the patient is unknown male trauma. He doesn't have a name. We don't have time to figure out what his name is. We have to book him in the system and have him already pre-booked if we can before the patient even arrives so that we have blood product in his name with his unit number under unknown trauma male. And so I don't even know who this person is. All I know is that he's roughly 45 years old and was flying a plane. So they pronounce him dead. Everybody has a collective moment of silence in honor of this person. And then everybody leaves the room. And all that's left is myself and the surgical resident who cracked open his chest. And the two of us are left to basically take care of the person who just passed away. So we have to clean up the disaster and get this patient prepped and ready to go to either the morgue or to the coroner's office if there's some suspecting of foul play or, homicide or anything like that. Oftentimes the victim has to actually go to the coroner versus to our morgue. So I start getting ready to clean him up. He's got dried blood all over him. He's got tubes and wires all over him. And the surgical resident has got to suture his chest back up because we can't just send him like that after we've cracked it open. So he's doing his thing. I'm doing my thing. And it's pretty lonely in that room. So we try to talk to each other to make it as best as possible after your adrenaline was so high and then it completely crashes down. And then you're left to deal with the body that's on the table. So I've got to clean him up. I've got to bag him up because we wrap him up in the shroud and we label him and everything so that we can send him off to the morgue or the coroner with the appropriate documentation. And that's how Fast, you go from 60 to 0 on a patient who dies traumatically.